Northern rural and remote settings, they often face clinical capacity problem. Northern Ontario has been experiencing that for decades. We're often considered a low resource setting. We have different clinical infrastructure. We have different availability of data and data infrastructure. And this is something that came out during COVID because our needs and voices weren't necessarily represented at those tables. Then they're forgotten in some of these overarching policies. The policies don't necessarily recognize or acknowledge the uniqueness of our infrastructure or geography or population. We have different population health profiles, patient experience profiles. How this operates in a northern rural remote setting is different, and policies don't necessarily accommodate. I'm Brianne Wood. I'm an associate scientist in social accountability and learning health systems at the Thunder Bay Regional Health Research Institute and Nawsum University. I'm an epidemiologist by training, and I'm the 2021 Health Research Foundation Health Systems Resilience Fellow. My research is on socially accountable learning health systems and specifically focusing on northern, rural, and remote settings and contexts. The idea of a learning health system, so a system that can rapidly generate and apply knowledge. And there's a direct link to health systems resilience, which is the fellowship that I was awarded. So that's the kind of work that I do. And not only am I interested in the applied part and actually creating the change, but I also want to advance the science on it, which is to better understand how do we build these types of health systems. With the practice-based research and specifically the Primary Healthcare Research and Learning Network, NORTH, we are investigating some more specific health conditions and healthcare utilization across the COVID-19 timeline. So 2 specific projects that we're working on right now. One is looking at youth mental health and more specifically how men and women, boys and girls between the ages of 10 and 24, how have primary care visits related to anxiety and depression changed after March of 2020. So we get the data, primary care visits and prescriptions related to anxiety and depression from before February 2020 and then after March of 2020 and look at rates of monthly visits. And our early analysis is showing, perhaps to no one's surprise, is that primary care visits increased, as well as prescription rates for anxiety and depression in both men and women, boys and girls, and across the different subset of ages too. I think mental health and substance use considerations, that's on the tip of everyone's tongue. That's a big priority. I mean, we can speak in broad strokes there. I think Ontario and many smaller regions have named that as a priority. Fast forward to 2022, and when we looked at our primary care data, we are seeing those trends. It's worth a deeper look because we can only garner so much information from primary care records. That doesn't include different community-based mental health services that people might be accessing. We also need to consider, hospital visits related to anxiety and depression during that same time period because perhaps those also went up, which would indicate a higher severity of people with mental health and addictions issues accessing care. So we have to look at different information sources to really dig deeper on what is going on with youth and mental health considerations in our communities. But it is true. I mean, there are many different instances and pieces of evidence that say in Northern Ontario communities and populations, mental health and substance use conditions are occurring in higher rates. They're occurring in greater severity, and we're not seeing any improvements over time. But we also aren't addressing some of the more basic problems. There are socioeconomic issues that can contribute to it. There are different intersections with poverty, homelessness, and I think from the healthcare perspective, we have been under capacity in terms of having an appropriate workforce and an appropriate remunerated workforce for decades. The lack of integration with social services just makes it harder to actually achieve those improvements. And because Northern Ontario, we're often grouped as a northern, rural, and remote setting, but we're actually quite heterogeneous. There are many different communities, many different preferences, profiles, and priorities, ways that they want to access care, that it's just really hard to actually accommodate all those needs when decisions are being made at the provincial level. I think what we need to do going forward is come from a strengths-based perspective and what is going well and where can we learn from other communities. I don't think that we can paint with a broad brush that all communities are facing similar challenges and want similar solutions, but I think it's about recognizing the differences and instead of focusing on the gaps that northern, rural, and remote communities face, it's about focusing on the strengths and solutions. And we can do that, and this is something that I focus on in my research program, by democratizing science and by creating a health system that learns and focuses on impacts. I mean, I think people, independent of their geography and health profile, want better health care. And the way that they can do that is by feeling empowered to access those things, feeling empowered to support decision-making in those areas. The way that things have operated in the past don't necessarily work, or they don't necessarily work for everyone. And so how do we integrate and bring together those different perspectives to actually address these real wicked problems?